Of this course for inviting me over, and it is always really very heartening for me and very welcome invitation for me when I'm asked to see my colleagues in the general practice because we have so much to share, and unfortunately the only place where we meet are these academic meetings, and I cherish the memories that I take along, and I always end up being wiser when I talk to my colleagues, and because you people, as I always say, are the icebergs, and we are only the tip of the icebergs in the tertiary care hospital. You see the burden of disease much more than we do. We only see disease much late when really there is very little reward in whatever we do. You are the people who are going to make all the difference in the community, in the prevention. I don't think we can practice any form of medicine without your support, and that is why I think it's always a very welcoming invitation whenever I get one from whoever to meet you and discuss things with you. Today, as you know, I have been asked to talk about peptic ulcer disease, and once again, this is something which we all encounter almost on everyday basis. I think this is one disorder which, if I can switch this, this is one disorder that we all are almost on everyday basis. We see a huge number of patients suffering from this, complicated by many other things, but definitely they do have dyspeptic syndrome symptoms or some form of abdominal complaints. So looking at the peptic ulcer disease as such, by definition it is the break or an ulceration in the protective mucous lining, that is mucosa of the lower esophagus, stomach or duodenum. As you can see, it can be superficial or it can be deep, but basically it is the breach in the lining of the mucous membrane of the stomach, and that is what we call ulcer. If it is a gastric ulcer, if it's a duodenal ulcer, of course that is the mucous membrane of the duodenum or of the esophagus. And remember, peptic ulcer can occur anywhere in the GI tract, but more common sites are of course stomach, duodenum and esophagus. Let me right from the outstretch clear some misconceptions that we have about the ulcer disease. Peptic ulcer is not always a stress ulcer. Of course, stress predisposes to peptic ulcer, but stress ulcer is a different entity altogether, which we get under physical or mental or emotional stress or some form of disease causing stress on the body, like uremia, hepatic failure and so on, or burns. Very typically the stress of the burns would produce an ulcer, what we call is Curling's ulcer, and that is a different entity altogether. Chronic gastritis is basically a symptom as well as a disease state that may lead on to peptic ulcer. It is the inflammation of the inner lining of the stomach, the mucosa, which obviously if continues can lead on to ulcer, but it is something which is different than ulcer. Dyspepsia is not a disease at all, it is just a symptom. And it could be a symptom of an ulcer, or it could be a symptom of so many other ailments. But it is basically a very, very common symptom that I think in the lifetime almost all of us have suffered dyspepsia at one stage or the other. It is such a common symptom that if we study the population and ask them about dyspepsia or dyspeptic syndromes, almost 90% will accept to be suffering at some stage from these symptoms. Peptic ulcer, of course, you can suspect on clinical grounds, and that is very, very important for a general practitioner to understand that you cannot, it's a diagnosis which requires investigation, and the gold standard, of course, is endoscopy. You can suspect peptic ulcer, you can have a high index of suspicion, but if you want to diagnose it, you have to look at it through a camera or through an endoscope and demonstrate that there is a breach in the lining. So it is an endoscopic diagnosis, just like Parkinson's disease is a clinical diagnosis. You know, there are many things which we diagnose clinically, like Parkinson's disease, motor neuron disease, where there are no investigations required. But unfortunately, peptic ulcer disease is a diagnosis which does require endoscopic evaluation. As I said, dyspepsia, probably one of the commonest symptoms that we all encounter. And it is in fact not a single symptom, it's a group of symptoms which alert us to consider disease of the upper GI tract. So it's a very vague definition that any symptom which could alert us to investigate or look into the upper GI, maybe it is reflux or whatever, or maybe pain in the upper GI or whatever, we could call it this symptom a dyspeptic symptom. There are basically two types of symptoms in dyspepsia. One, what we say ulcer-like symptoms, and dysmotility-like symptoms, or they could be combined together, very commonly producing heartburn and retrosternal burning, which is a very common issue. So some of the patients will have ulcer-like dominant symptoms where pain will dominate and epigastric burning, which may improve or get worse with food. You know, that will be dominant, ulcer-like dominant symptoms. Some individuals will have dysmotility-like symptoms when they'll complain of nausea, bloating, gas, gola, you know, early satiety, पेट भर जाता है थोड़ा सा खाना खाने से, and it could also get worse with meal. And that is that there is a motility problem in the GI tract. Probably the gastric emptying time is prolonged. Probably there is a reflux, lower esophageal sphincter is lax. You know, your mind goes toward the dysmotility disorders. If there are symptoms which are ulcer dominant, then you think of acid and peptic problems, increased acid secretion, increased acid pepsin digestion, or decreased mucus production, which is of course protective. Very commonly, these patients with dyspepsia will suffer from anxiety, and they will be very anxious look. And you know, you can even tell them when they are entering the clinic that they do suffer from a degree of dyspepsia. GERD is important to discuss because we talk about it a lot, gastroesophageal reflux disease. Again, it is one of the very, very common disorders that we all encounter. Why we need to discuss it in a little bit of detail when we talk of ulcer diseases, because it has major impact on the community. A lot of working days are lost, a lot of consultations are because of GERD, and a lot of medications and a lot of budget is utilized in the diagnosis and treatment of this. Now also it's important to review GERD because now we have a better understanding of what GERD is. We used to call it reflux esophagitis, Barrett's esophagus, you know, God knows what and what. But now I think more appropriately we call it GERD or NERD. We'll discuss this. But since we have better understanding, I think it's important to review the knowledge a little bit. Also, this is important to diagnose because this is a pre-malignant condition. We all know that it can lead to adenocarcinoma of the lower esophagus or of the stomach even in certain cases, and it's important from that point of view to diagnose it on time and to treat it. Then obviously there are management issues. It's something that I always tell my patients that it is a lifelong disorder mostly, because the patient needs to live with it. Unless we use new therapeutic tools, we do ligation through endoscopy, or now there is a very, very good study coming on out of US and one from Europe, where they have used laparoscopic surgery to get rid of GERD very effectively. But obviously right now our surgeons, I don't think they are that well trained in, they are excellent, they are super in taking out the gallbladders, but this is being done laparoscopically, but our surgeons are generally not doing it as yet. So there are newer therapeutic tools and interventions that one can use with GERD. As I said, if you look at symptoms that occur on weekly episodes, then 25% of the population will complain of that GERD symptoms. They'll say once a week they do have. If you talk of prevalence in last 12 months, almost 50% of the individuals will say yes, they have had symptoms of heartburn or dyspeptic symptoms or whatever because of GERD. And if you want to know about the lifetime prevalence, then it goes to almost 70% or 65%. So it's a very, very common disorder that I think the majority of the population at one time or the other will. In Asia, we know reported prevalence is low because I think there is lack of awareness on the part of the patient. Patient thinks it's bad hazmi, and the doctor also says, okay, you have taken chilies or you eat out a lot, although there is no evidence that taking chilies or eating out will make GERD worse. But we generally would relate to abnormal food habits or something, and we'll pass it as usual or normal or whatever, and just tell him to avoid chilies and avoid eating out or whatever. Generally, the symptomatology is mix of dyspepsia as well as heartburn. Sorry about that. Okay, when we look at the GERD spectrum of disease, there is two types of disease. One is esophageal and the other is supraesophageal, or what we call is C-GERD. Okay, this is very, very important that we have two types of spectrum of diseases. One is esophageal disease or below the diaphragm disease. One is above the diaphragm disease. Where above the diaphragm, now GERD is supposed to be very closely associated with pulmonary pathology, especially worsening of the bronchial asthma. You have a patient who gets repeated attacks of bronchial asthma, a middle-aged lady, think of GERD, because GERD could be producing bronchial asthma or having pharyngitis repeatedly, tonsillitis repeatedly, and many times these patients have had their tonsils out and they have ended up having more and more problems. So remember, GERD can very commonly lead to supraesophageal disease like asthma, cough, phlegm, and so on. Also laryngitis, one of the causes of laryngitis is GERD, and it's a very much curable and treatable cause once we know it. It's important to know. And also it can lead to dental caries and dental erosions, and we have done a study, in fact, with Dr. Nazia Yazdani recently, where we looked at patients presented with advanced gingival disease to them, and about 12% of them had GERD as a associated factor responsible for that. So, acid reflux is poison not only for the bronchi and larynx, but also for the teeth, mouth ulcers. Even rhinitis has been known to be associated with GERD quite commonly. On the esophageal side, of course, it's erosive esophagitis, Barrett's, leading on to adenocarcinoma. You have NERD, which is negative endoscopic reflux disease. That's an important entity where you do endoscopy and endoscopy is totally negative. So we call it NERD, negative endoscopic reflux disease. Reflux could still be there in spite of the normal endoscopy. Then we have, in some patients, we have seen acid-sensitive esophagus, and also esophageal disease can be responsible very commonly for a non-cardiac chest pain. When we examine our final year, when we ask them about the chest pain, we expect them to come up with a differential diagnosis apart from angina, MI, pericarditis, to say esophageal disease like GERD. Because GERD, diffuse esophageal spasm, it very closely mimics the cardiac symptomatology, and it's important to differentiate the two. Coming back to ulcer disease now, that those were the variants and important ones. If we look at the quick stats, there is about 10% lifetime incidence. If you look at the population of Lahore, and whatever the population is, the 10% patients will have lifetime prevalence of ulcer. One time or the other they had suffered an ulcer disease. So again, it's a very, very common disease. If you look at the population, the cross section, right now how many patients have ulcer disease? Probably 2 to 3% of the population right now will have on a cross section, they will have a ulcer disease right now. So it's an extremely common disease, a very, very common disease. And of course we do not have the data, but US spends a lot of money on treatment of these disorders. It's a very expensive disease to treat. What has happened over the years from 1970 up till now, because of the H2 receptors, prostaglandin analogs, and then PPIs, and now also other newer drugs, and also treatment of Campylobacter and so on, that as you can see, the uncomplicated gastric ulcer and to some extent duodenal ulcer after the invent of PPIs and H2 receptors had gone down. Okay, but still it is 3% on the cross section area. But the perforation rate and the hemorrhage had not reduced, rather the hemorrhage had increased, and especially hemorrhage from duodenal ulcer had gone up. I think the reason is we are prolonging the survival of the patients. Longevity of life is more now, so we are seeing more elderly diseases, more atherosclerotic ulcers which bleed and bleed profusely, they don't stop. That's the problem with the elderly patients. What are the type of ulcers that we encounter? Of course, one is gastric ulcer, which is slightly more common in males than the females and more common in the elderly. It's an aging disease. Most commonly it is located in the lesser curvature of the stomach near the antrum, near the pre-pyloric area. That's the typical site to look for when we are doing an endoscopy. But the most important fact is that about 1 to 3% of these ulcers, they may be young patients even, they may be malignant. When you have a gastric ulcer, you always think of malignancy. And age is no bar. You have a patient of 25, 30 with gastric ulcer, you'll have to biopsy, because that's the only way to exclude the malignancy. You cannot just leave it at that. Gastric ulcer is a much more serious disease from this point of view, that there is associated chances of malignancy, and we don't know exact defect, but basic defect is the opposing forces, the defenses of the body, and also the attack from the acid and pepsin, and the defense which is basically mucus secretion. There is some problem with either mucus secretion is not good, or if it is adequate, the quality of the mucus secretion is not good, or there is more acid and pepsin digestion. So it's the imbalance between these which causes ulcer. Duodenal ulcer is never, almost I'll say never ever malignant, so we need not worry about it. We usually do not re-endoscope them to find out if they have healed or not. We go on symptoms because they are never malignant, so it doesn't matter. But it is more likely to be culprit in chronic disease. If you have a patient who is presenting acutely with acute onset pain for last 5 days or so, middle-aged, it's more likely to be gastric ulcer. Duodenal ulcer is he has had these symptoms for ages and they are exacerbated, remissions exacerbated, he's more likely to be suffering from duodenal ulcer. Duodenal ulcer disease, usually the symptomatology is they get better with food intake. Duodenal ulcers, so they eat more and they're usually a little bit on the heavier side. But gastric ulcer people, well, if they have malignancy, of course they'll lose a lot of weight, but they will lose weight because of the symptoms point of view. When they eat, they get a lot of pain, so that is why they avoid eating the gastric ulcer individual. This is very important to understand that in the normal situation we have damaging forces in our GI tract, mainly in the duodenum and stomach, which is acids secreted by the gastric cells and also peptic enzymes secreted, and they are supposed to be digesting together. When they get together, they are supposed to be sterilizing the food that we eat, and they are supposed to digesting the proteins that we eat. Okay, that's the whole idea. But the main thing is, why then they don't digest the stomach itself? Because they are supposed to be digesting the proteins, and stomach is a protein. I mean, of course we eat sometimes stomach of the cow or of the goat or whatever. So it is a protein that we eat. It's a high protein, the gastric walls. So why it doesn't digest the stomach wall itself if it is supposed to be digesting the proteins? Well, the reason is that there are defensive forces in the stomach and duodenum, which is basically mucus. I think 90% of the protection comes through the mucus. It is thick, viscous, lace-like, it is a jelly-like material which is secreted by the, again, gastric and duodenal cells, and it coats or paints all the villi of the stomach and duodenum. So the acid is there, it is digesting everything in the lumen of the stomach and duodenum, but it cannot digest this because there is something protecting it, which is mucus. Now the main thing is this mucus, quality and quantity. These are the two important things. From how it is made from blood. The more the blood flow to the stomach, the more mucus is produced. The thicker the mucus is produced. The lesser the blood flow to the stomach, the lesser the mucus production. It's very simple, because obviously the whole sodium, potassium, ATP and all the elastins that is there, they are secreted by the blood. So the emphasis is things which reduce the blood flow to the stomach lining, they will produce ulcer, because the mucus quality and quantity will be low, like non-steroidal anti-inflammatories, like Helicobacter, stress. So everything is dependent. It's just like ischemic heart disease. The lesser the blood flow to the stomach, the more the chances of ulcer disease, because the production of mucus, both qualitative and quantitative wise, will be low. Also, mucus does have bicarbonate secretion, which is mainly in the duodenum, coming from the pancreas, and then the mucosal blood flow. These blood vessels are extremely important. If they are arteriosclerotic, they are thick, clogged, blocked, or they are vasoconstricted because of the non-steroidal anti-inflammatories. Now, non-steroidal anti-inflammatories will counter the prostaglandins. They are supposed to decrease the blood flow to the joints, because they are supposed to be anti-inflammatory. But they do not do so only in the joints, they do so all over the body. So that is how the blood flow is reduced, because they inhibit prostacyclin, prostaglandin E2, I2 and F2, and all the vasodilatory prostaglandins are inhibited more, and thromboxane and other vasoconstrictive are increased. So because that they are supposed to be doing the same thing in the joints, they do that in the joint, but at the same time they do so in the stomach, that they inhibit these prostaglandin. Then also important thing is that this apical surface membrane transport activity and also the regenerative capacity. Constantly the GI lining is being renewed. You know, just like skin, we are getting new GI linings constantly at the rate of turnover of around 3 to 8%. We are having it renewed, because the old cells are renewed by the new cells growing from regeneration. This depends upon the local and systemic growth hormones. And if you have problem with growth hormones, local growth hormone or fibroblastic proliferating factors and things like that, then you will obviously not renew this lining that quickly, and you will develop more ulcer disease. Or more commonly, the damaging forces and the defensive forces, both are, there is less defense and more damaging forces which are acting in conjunction to produce an ulcer disease. As I said, how will the increase the damaging forces occur? Of course, I had already discussed non-steroidal. H. pylori, we know that it secretes mucosulfatase enzyme, which digests the mucus, which breaks the linkages in the mucus. And this enzyme that is produced by H. pylori will break the mucus and expose the underlying gastric mucosa to the acid and pepsin, and then the acid and pepsin will digest it. Similarly, aspirin, cigarette smoking is known risk factor for ulcer disease, because it increases the acid secretion by about, if you smoke to 15 to 20 cigarettes, and if you are not smoker, you are forced to smoke this, or as a volunteer to smoke, you increase your acid secretion by about 60%. So it does increase your acid secretion. And also there is an evidence that it contributes to the poor mucus secretion. Alcohol similarly is inflammatory, causing gastritis by itself, and if taken on an empty stomach and if taken on a regular basis, it is a well-known entity that alcoholic gastritis can occur. Gastric hyperacidity, again very important. People ask me, okay, what is this disease? You know, we are secreting more acid, we take medicines, we get better. We stop medicine, again the disease comes back. Obviously you need to exclude these factors like Helicobacter and things like. And once you have done that, then you tell your patient, what I do is I say, it is this disease, hyperacidity or increased acid secretion, is just like diabetes and hypertension. Just like your blood pressure is up for rest of the life and you need to take medication or do something about it, lifestyle modification or whatever. For diabetes you need to do same. This is a chronic disease, and remember, it is better you counsel the patients on the positive side that they need to live with it. They need to adopt their lifestyle, and they need to know about medication so that they can start when they are enjoying their holidays in Nathya Gali or somewhere. They need not, break those holidays, give them some quality of time, provided we can counsel them and they understand the nature of the disease in a better way than what do they do. Otherwise, what they do is they keep on going to hakims, homeopaths, quacks everywhere, and that makes the things go worse. Psychological stress, I'll talk about, that's a risk factor, and also rapid gastric emptying.
Rapid gastric emptying, how it increases the...
Yeah, actually, the motility of the stomach, if it increases for whatever the reason, if it is a foreign body mediated, food mediated, in fact milk increases the motility. And what happens is, once the motility is increased, you secrete more thromboxane and inflammatory peptides and less vasodilatory peptides, and that is why the blood flow to the stomach is reduced, because there is vasoconstriction somehow. Okay, it is taken as an injury, and then the reflex vasoconstriction, histamine is released more, histamine induced acid secretion is increased. So it's basically histamine mediated and prostaglandin. That if you do motility studies and if you increase the motility of the stomach, the histamine in the stomach cells are increased, and also the vasoconstrictive prostaglandins are increased, and vasodilatory is less. Yeah, but I'll talk about it when we talk about the treatment. You are absolutely right. We do use prokinetic drugs if there is a dysmotility-like syndrome, what I discussed in the beginning, but not if the ulcer dominant symptoms are there. That's why I went into that symptomatology. Prokinetic drugs like cisapride or motilium like drugs, domperidone like drugs, it is okay if there is dysmotility like syndrome, but these drugs we usually give anticholinergics to ulcer like dominants, although we don't use them but our teachers used to use anticholinergic to inhibit the stomach motility, and that would help the patient to relieve the pain. Of course we don't do it now because we have better agents that we'll discuss about, but generally that's it. And then what about the impaired defenses? Decreased mucus secretion, decreased quality or quantity of mucus, decreased prostaglandins, whatever the reason is, if you're giving antiprostaglandin drugs, and of course delayed gastric emptying. That again is impaired defense. Now you have to understand that both delayed gastric emptying and also increased motility are counterproductive. You have to have the right balance. The emptying time of the stomach is around 35 to 40 minutes. If it goes above 1 hour, usually there is a reflux duodenal secretions coming into the stomach. Okay, if you dilate the stomach, then the duodenum usually refluxes back into the stomach. What we call is duodenal pancreatic gastritis can occur. If you have increased motility below 15 minutes, again that's counterproductive. So right balance is to be maintained. So risk factors, we did a study, European Journal of Gastroenterology 2003, again, one smoke 33 to 100% more likely to develop duodenal ulcer. Smoking is more associated with duodenal ulcer than the gastric ulcer. And these are not just smokers of cigarettes, they are hookah and all sorts of smokers that we took over. And of course, because of the decreased blood flow to the stomach and arteriosclerosis, nicotine causing vasoconstriction, it can also retard the healing of identified ulcer. And there are a number of studies which show that in smokers, a gastric ulcer is more likely to become malignant than non-smokers. Increasing age is a risk factor. In males, you tend to have more gastric ulcer. Alcohol in moderation is okay, but if you don't dilute it, again it can cause ulcer disease and gastritis. Diet, milk. Now this is very important. There is a misconception that, and amongst the patients, and I think some of the colleagues, there is a misconception that milk helps. In fact, milk has a counterproductive effect. Milk does help a little bit of symptomatology like an antacid thing, but there is a good deal of evidence. There is in fact one study from India, from Karnataka, south of India, which very clearly shows that if you give milk in the bolus form or a drip form, it increases the reflex acid secretion. So milk might relieve the symptoms there, but after 4 or 5 hours there will be increased acid secretion and there will be exacerbation of pain. So generally it is recommended that the milk intake should be in moderation. Tea and coffee, I usually tell them cool down a little bit, don't take it too hot because it will cause a physical trauma if you take it too hot. Cool down a little bit and then take it. Don't just take it too hot. Coffee is in moderation. I think 1 to 2 grams of beans grounded is supposed to be protective in fact. But again, excessive coffee intake is, and again, coffee has to be taken little bit, the temperature has to come down before you take it. People in the habit of taking too hot a coffee can get esophagitis and things like that. Stress, obviously, as I said, is a risk factor for this. NIC, a non-steroidal anti-inflammatory, if you have an ulcer patient and if he doesn't have H. pylori, then he is likely, the next common thing is non-steroidal, that he's taking some form of analgesics, whether you have prescribed it, somebody else, or he himself has self-prescribed. But that is the second most common cause of ulcer disease after H. pylori. If the patient is on non-steroidal and ulcer has been identified, that patient is more likely to perforate or to bleed. That's also important. And the risk of gastric ulcer increases by about 6 times if you take more than 3 aspirins a day of 300 milligram. If you cross a gram line, then the blood loss is enormous, and the chances of ulcer disease increases by about 6-fold. Low dose aspirin, there is increased, in fact in Karachi, Professor Samad has done a study that it can cause, normally the blood loss is around 5 to 10 ml, as you know, it can cause about 15 ml of blood loss per day. There is slight increase in risk, but the low dose aspirin, the benefits overweigh this risk. But certainly high dose aspirin and also the other non-steroidals are, we try to.
Even the injectables,
we must, well, I'm glad you brought up this point. I don't think there is any role of any injectable non-steroidal in any disease. This is something which is not heard of anywhere in the world. When people come to sell you injections of diclofenac and leomycin, ask them to show you whether these drugs are available in UK and US, or bring BNF or bring FDA formulary. They are unheard of. There is no role of injectables non-steroidal, because not only they are more, because the damage, it's a misconception, is not local, it's a systemic damage, and also it can cause rhabdomyolysis. It's a painful injection, abscesses, and the absorption is equally good if you give through the injectable route. the absorption is then obviously through the venous channels, and here the problem with these drugs is the absorption is so quick that they inhibit the prostaglandin, so there is no role of injectable non-steroidals, and obviously even if you give injectable, the GI symptomatology remains the same. In fact, interestingly, there is no study in the world which is done on injectables because they are not available anywhere.
So they say local irritation in the stomach.
Local irritation is one factor if your mucous secretion is abnormal. But that I will say is 5% of the factor. 95% is systemic. Your systemic inhibition of vasodilatory prostaglandin and your decrease in growth hormone, local growth hormones because of the decreased blood flow. Because this has been proven in animal studies and everywhere. You could get gastritis if you take these drugs empty stomach, but we don't give them empty stomach in any case. So if you look at patients who are taking non-steroidal and just endoscope everybody who is taking, around 10 to 30% will have ulcer disease. If you are giving it to 100 patients, about 4 to 10% will have duodenal ulcer, and clinically significant ulcer will be present around 4%. So it's a very, very common entity if you are giving non-steroidals a lot. This is very important because this is the hazard analysis. Which patients are likely to have serious adverse effects from non-steroidal? Well, if somebody has bled, there is a history of bleeding in the past, that he had a GI bleed, now the ulcer has healed, he has, a very high chance of rebleed, around 13.5%. If somebody is on anticoagulation or even antiplatelets, still he has a higher chance, of having a serious adverse event. People on corticosteroids, again quite high. People on low dose non-steroidal still have about 3% chance. High dose non-steroidal around 6% chance. Advancing age has more adverse effects than the younger patients. So in an elderly, in somebody who has bled, in somebody who has used steroids or something, it is a volcano situation in any case. Well, I'll talk about that. I have it. Okay, we can talk about that now. COX-2 inhibitor came with a lot of promise, as you know, celecoxib, rofecoxib, and we thought this might the answer because they were very selective, and they were more friendly to the kidney and to the GI. But then obviously the recent data last year, as you know, there were increased strokes and now increased MIs. So really the risk of long-term use outweigh the benefits. Of course, they are very limited use now. In somebody who has renal disease and you are forced to use these things, maybe you can use it. But just for GI protection, because of the increased risk of strokes, and they are elderly, especially elderly patients, increased risk of strokes and MIs and occlusions, blood vessel occlusions, you don't use them. How NICIDs will cause the mucosal ulceration? There are a number of factors, as I already said, because if you look at prostaglandin E2 and I2 mediated inhibition of acid secretion and cytoprotective effects, it counters that, and because of the non-inhibition of the acid secretion directly, you got ulcer disease. Also, the loss of I2 induced inhibition of leukotriene mediated endothelial adhesion and activation of neutrophils is inhibited. There is increased leukocyte endothelial interaction, adhesion molecules are increased, the inflammation is more, the platelets are activated more, there is supposed to be capillary obstruction leading on to ischemic injury, and also because of the prostaglandin inhibition, you generate more free radicals, there is less free radical squinging there, and you have endoepithelial cellular injury which leads on to. So there are multiple ways, and they are all, as you can appreciate, are systemic ways and not the local ways where they cause the ulcer disease. Stress Experimental stress does lead to decreased upper GI blood flow in animals, but Levinstein from Mayo Clinic thought that effect of stress seems to be reversible. Once the stress is gone, the blood flow does increase back to the normal. This is a study that we did in North Medical. Again, when we endoscoped the ulcer patients and interviewed them, our investigators interviewed them, ulcer patients are more likely to be suffering from psychological problems like pessimism and depression, and also drug dependence was much more in them as compared to people, general public who was not suffering from ulcer disease. Generally, the same finding has come from Feldman, who thought there are personality problems associated with ulcer disease, and studies have found strong association with drug dependence and ulcer disease. Of course, we all know this Helicobacter pylori or Campylobacter keeps on changing the name, responsible for the Nobel Prize win a few years ago. As you know, again, Keller and his colleagues won this award, and you know, they live in the gastric mucosa. Again, these gram-negative organisms are thriving there in the acid, secreting glucosulfatase enzyme, which digests the mucus down there, exposes the underlying mucosa to the acid and the pepsin, and then the digestion takes place. As I said, it's a gram-negative spiral organism, one of the most important risk factors for duodenal ulcer and variable risk factor for gastric ulcer. 10% of the healthy population, and I suppose in Pakistan more than 10% under 30 are carrying this bacteria. 60% of the healthy people over 60, probably in Pakistan I can say 2/3 of the population may be suffering from carrying this bacteria, will cause disease in about 1/4 of those infected at one stage or the other. And remember, whatever said and done, you have to eradicate it just like any bacteria. You have to really kill it. There is no spontaneous remission here that you treat the acid with a proton pump. You have to give antibiotics and the proper course in a proper duration. Diagnosis, very quickly. Generally, the symptomatology is very variable, but generally the vague discomfort and feeling of gnawing hunger. Duodenum has a generally more predictable relationship occurring after about 3 to 4 hours of food intake. Gastric ulcer may be immediately after the food intake, but it has a variable relationship. Gastric ulcer patients do lose weight, as I said, and duodenal ulcer patients tend to be heavier. Many patients just presents with melena, and they even don't know if the melena is there or not. So I think we must ask the patient positively if he had passed black tarry stools. Many times, I mean, like I have really seen one of the professors, the principal of a medical college, presenting to me with weakness and with dizziness, and when asked, he had melena and, you know, God knows what, and then we, you know, hospitalized, gave blood, his hemoglobin was. So, you know, even educated people might ignore this symptom because of the modern flush system and things like that. They may not be even aware of melena. So that's why we need to do PR in these patients, because you could get finger stall soiling with the melena stools. That is what I was saying. The rectal examination is important. Physical examination generally negative, except maybe epigastric tenderness, but obviously nothing here to give away. Radiography is fairly sensitive, but again, more problems with this preparation, quality of radiographs. The cost now is quite high, and remember, as I said in the beginning, endoscopy is the gold standard. It is, peptic ulcer disease is an endoscopic diagnosis. We have to accept it, that it's a very sensitive test, detecting around 95% of the gastroduodenal ulcer. And of course, the advantage is you can also do a biopsy of a gastric ulcer, or you can inject a bleeding ulcer, or you could inject a varices if you don't know what is causing this. So you could have an interventional advantage. Ultrasound, I'm sorry about the spellings, is generally a useless test. Now this is what I wanted to talk about for a second, because very commonly on the ultrasound it is written ulcer disease, gastritis. If you would agree with me, we have seen a lot of reports of certain ultrasound, biliary gastritis even, and even God knows what. Remember, it is not an ultrasonic diagnosis. So ultrasound is supposed to be normal. We should not be asking for ultrasound if we are suspecting ulcer disease. We should be requesting for an endoscopy. And very commonly we see, I think they ask symptoms while they are doing ultrasound, and once the ultrasound is negative, there is no gallstones, they say ulcer disease. And the patient then runs around, takes anti-ulcers or whatever. And so remember, this is important observation. Diagnosis of H. pylori, there is an invasive way of doing it. When you do the endoscopy, do the biopsy, do the histology, which is quite sensitive to, and with a good histopathologist, around 90% of the sensitivity is there, and 100% specific, because you can't mistake it for anything else once you see it. You can do on the biopsy specimen rapid urease flow test, which Professor Siptulisnan used to do a lot when he was in Mayo. I'm sure he's still doing it, and RF must be doing it. We can check it with non-invasive IgG antibody, and especially if we have rising titers of antibody detection. That is also. Urea breath test is quite sensitive and specific, but you do need a machine for it, and you need to blow into a dish and on a cartridge, and then that cartridge has to go in a machine. It is based on the carbon dioxide liberation when there is a digestion of the mucus, and then it comes into the breath, and you tend to check it as a urea breath test. But again, as I said, it does need some gadgetry. Complications of the ulcer, of course, the perforation, as I said, recurrence is very, very high. Obstruction, especially the pyloric and pre-pyloric obstruction, bleeding could be life-threatening, especially in the elderly, and of course malignancy in case of gastric ulcer, as I said. Upper GI bleed is one of the most common medical emergencies as a complication that we see. About 5 lakhs patients are admitted in US alone per year, and the incidence is around 100 per 100,000 patients in adults, and incidence increases by about 20 to 30 folds if one is lucky to live beyond 80 or 90 years. However, GI bleed in young patients especially does stop spontaneously in 80% without being even recognized. But it's important to ask for that history, because, as I said, then you will not be using non-steroidal and things like that in those patients. These are the international data, but in our own data, the varices is probably the commonest factor. But if you look at the global data and compare it, this is, again, we did a study in Pakistan Journal of Gastroenterology long time ago, but now varices are much more commonly associated, duodenal ulcer and gastric erosion following it. Therapy at the end, of course, is to heal the ulcer and to prevent recurrence if possible as effectively as we can. If the H. pylori is present, to eradicate it and make sure that it is eradicated effectively. And if there is severe pain, to treat the pain with codeine or some dextropropoxyphene or some form of analgesia. Non-pharmacologically, I had already talked about it. I won't go in detail, but lifestyle modification does help, like quitting of the smoking, moderation of the milk intake, the discontinuing of non-steroidal, and as I said, COX-2 inhibitors do help because they are more selective towards joints and they do not inhibit systemic prostaglandins, especially to the kidney and GI, but then there is increased chance. Should be curtailed as much as you can. You see, I usually tell them in acute stages not to take milk, and once they have the symptomatology is resolved, to liberate the milk intake gradually. Approach to the dyspepsia, as I said, important thing, as I said in the beginning, is evaluation, whether the patient is suffering from functional type of problem or a structural problem, or patient have red flag signs or alarm symptoms. This is very, very important. That is it dysmotility like dyspepsia or ulcer-like dominant dyspepsia. This is very important to differentiate. And if the ulcer-like dominant is, then obviously lifestyle modification, test for H. pylori, breath test, or IgG antibody or invasive testing probably would be the best option. And if it is present, eradicate it. If it is negative, then trial of acid suppression. And if it is a dysmotility like, then what Chima Sahab said, we'll use prokinetic agents if there is more gas, gola, and less heartburn or reflux symptoms. Sorry about that. I won't go in detail because of the interest of time, but you need to eradicate H. pylori. Only just antibiotic won't work. I'll talk about 1 or 2 studies, but you can use any one of these agents. Obviously in H. pylori or ulcer disease, we have cytoprotective agents which are mucosal protective agents or agents which enhance the quality of mucin. They do not affect the, okay, fine, I'll finish in that time. I'm told that I have 10 minutes left, so I have to little bit rush, but I think we are on time, no panic here. So cytoprotective agents, I'll talk about them a little bit. Then you have H2 blockers, you have prostaglandin analogs, you have proton pump inhibitors, and you have symptomatic drugs like antacids. So you get some symptom relief, but no documented healing. H. pylori, if present, should be eradicated. Reduction of gastric secretion or neutralization of the acid, and also mucosal protective agents. They can all be used in combination for quick relief. Generally clarithromycin for 14 days, we use 10 to 14 days, but 14 days is better. 250 milligram thrice a day, or add ampicillin to clarithromycin in resistant cases, and usually omeprazole along with it for the initial relief. Okay, I'll talk about couple of studies also, and this will give you an eradication rate of around 80 to 90%. Control of gastric secretions, as I said, acetylcholine, histamine, acting on acetylcholine, anticholinergics, histamine blockers, anti-gastrin drugs, and prostaglandin analogs I already talked to. Again, you know, you can remember the acid secretion. If you, this is the pool of gastric secretions, and you know, basically dependent on acetylcholine, histamine, prostaglandin, gastrin, and then the mucosa over there protecting. Now you can, just from this slide, you can see that you have drugs which act as anticholinergic like prinziprine and cholinergic receptor blockers over there, and stops the calcium influx to the proton pumps and blocks the proton pump activity there. You have H2 blockers which block the histamine effect but do not block the acetylcholine, prostaglandin and gastrin effects, which are specific for histamine blockade. Of course, that's why they are not that effective. Or you can have prostaglandin receptor drugs which are prostaglandin analogs, which will increase the blood flow to the stomach, and ulcer healing will take place that way. Or you can use the common pathway right at the end and block the proton pump, hydrogen potassium ATPase activity blocked in the proton pump, which pump out the acid secretion like omeprazole. So really this slide gives you an overview. Or you can use drugs which will enhance the mucus secretion, and I'll talk about that in a minute. I already talked about H2 blockers. They are basically competitive antagonists of histamine and are more selective for the stomach, but they can exacerbate bronchial asthma and chronic bronchitis and things like that, because some of them, like cimetidine, is not that selective H2. It does affect on H1 blockers. You can use it for peptic ulcer, acute stress, and GERD disease. Adverse effects in high doses, especially cimetidine, is known to cause hallucinations, delirium, depression, can cause dizziness, diarrhea, and muscular pains. Cimetidine suppresses the cytochrome P450 system, so if you're giving other drugs which use cytochrome P450 system like warfarin and others, there will be potentiation of the effect of those agents, because this does inhibit that. This can cause gynecomastia, a painful gynecomastia, galacturia, because of increased prolactin secretion, and because of the also because of the decreased metabolism by the liver of prolactin. Prostaglandin analogs like misoprostol, PGI2, again increases the bicarbonate secretion, increases the blood flow to the stomach, and is effective that way, as I already said. Proton pump inhibitors like omeprazole, quite effective. Esomeprazole is more effective than the simple omeprazole, but obviously this is there is some cost benefit involved over here. They irreversibly inhibit proton pump, okay, so that the final common pathway, as I showed, they interfere with the oxidation of warfarin, phenytoin, diazepam and cyclosporine, so you have to monitor warfarin and phenytoin levels more closely if somebody is taking proton pump. There is this thinking that they might be in the long term associated with gastric cancers, because the acid is after all protecting from H. pylori, from so many things, and if you inhibit it for very long time irreversibly, maybe fungus, maybe gastric carcinoma is more common, but it hasn't been shown in even long term studies. Again, antacids, as I said, they are basically not very good promoters, and they do have a problem of sodium in hypertensives and cardiac failure and so on. Aluminium, remember, containing are constipated, and magnesium ones will produce diarrhea. Then we do have mucosal protective agents. This is one of my areas, which is my favorite area, and we have studied these agents quite effectively because they are non-systemic, they do not go to anywhere, they are just local with systemic effects. So we have been using this in burns patient in a study where this as effective as cimetidine IV in fact, and also as effective as omeprazole, as effective, and it is still non-systemic. Sucralfate is a complex of aluminum hydroxide and sulfated sucrose, and the important thing is once sucralfate is taken in, it is broken by the acid. You need the acid secretion. The important thing is sucralfate is useless if there is no acid. So if you are giving proton pump then sucralfate, it's not going to work. You have to give this when the acid is there. The more the acid, the more effective it is, because this is broken down, the long chain is broken down by the hydrochloric acid into sucrose, octasulfate and polyaluminum hydroxide. Polyaluminum hydroxide, of course, is an antacid that we know, okay, but sucrose octasulfate, as I just show you over there, it binds to positively charged iron group of protein that is present in the necrotic tissue at the ulcer crater, because remember the ulcer crater has dead material, necrotic material, and that obviously is positively charged there, and this octasulfate is negatively charged, so it gets an ionic binding which is very favorable, coating the ulcer crater. It can cause constipation if taken excessively, and that's one of the side effects. It can sorry about that. As I said, they are non-systemic. They do increase the prostaglandin synthesis in the stomach lining. In the animal experiments and even in the human, it has been shown to increase the blood flow without getting absorbed. And it does have anti-Helicobacter activity, and it can be used in most of the acid. And these are the dosage which I won't. There are many studies comparing it with cimetidine. Again, there are studies comparing it with omeprazole. Again, equally effective for H. pylori eradication and for ulcer healing. Glucosulfatase activity of H. pylori is countered by sucralfate taken orally. Again, won't go in detail because of the interest of the time. At the end, I'll summarize saying that APD is extremely common disorder, as I demonstrated. Even on the population base, if we look at, almost all of us do get these symptoms during our lifetime. As I said, this is something that one needs to live with. The hyper secretion, hyperacidity, just like any other chronic ailment. This is required lifelong follow-up and treatment. Be aware of the red flag signs, especially in gastric ulcer, especially if there is excessive weight loss, especially if the patient relapses, if there is a failure of healing, and especially if the patient is elderly. It is, this is where you need to refer these patients quite early. That is where the main emphasis lies, to refer early and to refer appropriate. Now, where to refer is important. I think if your patient is bleeding, then obviously he requires an inpatient treatment. There is no point in referring him